Moving on to the next session, that is the keynote speech on art of medicine. May I call upon Professor Piyusha Athapattu, Dr. Ranga Gunasekara to chair and conduct the next session. Over to you, ma'am.
Good morning. It's my pleasure to introduce my mentor and guru, Dr. Bandula Wijesiriwardena, who's the current chairman of the Lanka Hospitals and consultant physician. Dr. Wijesiriwardena is an honorary fellow of the Royal Australasian College of Physicians and the College of Medicine South Africa, and a fellow of the American College of Physicians and the Ceylon College of Physicians. Dear sir, it is my pleasure to invite you to deliver.
Thank you, Piyusha, for that introduction. Good morning, everyone. Let me first thank Sri Lanka College of Internal Medicine for having invited me to deliver this lecture today. And when I look at the theme, enrich clinical competence with compassionate care, it's all about, I think I'll be talking most about that part, that theme in my lecture of Art of Medicine. So medicine, is it science or an art? Medicine is both a science and an art. Medicine is not a pure science as physics or mathematics that we studied. It is an applied science. Art of medicine is the application of the scientific knowledge that you have obtained during your medical school time to the patient. Art involves skills acquired by experience and or observation. A good doctor has to be an artist armed with scientific knowledge in medicine. In other words, medicine is an art based on science. The science of medicine is founded on scientific knowledge obtained via basic sciences such as anatomy, physiology, and biochemistry, and scientific research providing evidence-based medicine, or what we call EBM. EBM obtained through quantitative research and is widely accepted. Quantitative research methods incorporate only questions and phenomena that can be controlled, measured, and counted. But we all know that clinical decisions and methods of patient care are based on much more than evidence-based medicine. Clinical knowledge consists of interpretive action and interaction, factors that involve communication, opinions, and experiences. The art of clinical knowledge goes much beyond measures and numbers. This is what you call quality. How a doctor interacts with a patient and families, whether he displays humane qualities, and how the patient is examined, etc. Qualitative research involves systematic collection, organization, and interpretation of textual material obtained from talk or observation. It allows the exploration of social events as experienced by individuals in their natural context. Qualitative inquiry could contribute to a broader understanding of medical science, but however, it's much more difficult to carry out. The art of medicine simply means the clinician's way of being when interacting with patients and families. The art of medicine is a strong foundation of practice. It is permanent and based on human values and intuition. It allays anxiety and consoles under all circumstances. Whereas science of medicine, the scientific truths are not always true, not true for all times. Today's truth may be tomorrow's folly depending on new evidence that is available. There is art in listening to patients, and there is art in understanding the patient's narration, being able to read between the lines and knowing when to question. There's an art to caring and developing relationships with the patients. There's art in understanding what a patient is willing to do and able to do. And there's an art to examination. How do we manage a patient? So when we start managing a patient, the one can cure sometimes, but care for and comfort always, right? One has to make a diagnosis to cure, but doesn't need a diagnosis to care for or provide comfort. To make a diagnosis, one traditionally relied on history, clinical examination and clinical judgment, and results of laboratory investigations. History providing about 74% of the information, and clinical judgment and clinical examination about 12 to 25%, and lab investigation 11 to 15%. Above figures show the importance of history and examination. They are the cornerstones of diagnosis. Clinicians increasingly move away from bedside and rely more and more on diagnostic tests. So as a result, the diagnostic process is followed in a reverse order, leading to an erosion of art of medicine. Listen to your patient. He is telling you the diagnosis. William Osler, the great physician, taught his students in the late 19th century. His words are still true today. I'm just giving one example to show how important the history is. I came across this 72-year-old lady admitted with a headache, generalized aches and pains, and insomnia. Seen by a neurologist for the headache, and I was asked to see regarding other medical issues. She developed recurrent GTCs 3 days later and went into status. Biochemistry, MRI, brain were normal. Each of us was compatible with seizure activity. It was controlled with medication, and she was put on long-term anti-epileptic drugs. She continued to have insomnia. History revealed that she had been on long-term diazepam and stopped by the neurologist on the day of admission. When I asked the patient, she said, right, because it's not a drug that is given for insomnia, there are much better drugs nowadays, so he would strongly advise stopping it. So as the patient was advised to stop. So it was on the third day of stopping the medication, she went into status. So it's due to withdrawal. So no amount of investigation, MRIs, CTs, EGs would tell you what the diagnosis. It is the history. If you don't go into the history carefully, and you are going to miss. This is just one example. I can give hundreds of examples. So importance of the medical history. Medical schools world over have realized this. And history taking is again being given a lot of importance. The field of narrative medicine is being introduced into the curricula. Narrative medicine, this term refers to training in interpreting literature and applying that skill to understanding the accounts of patients. And the patient's histories are considered as narratives or stories. A literary element or narrative element is an essential characteristic of all works of written and spoken narrative fiction. Just to outline, the elements of literature include plot, theme, character, and tone. The plot means sequence of events in which each event affects the next one through the principles of cause and effect. Theme means central topic to a story. If you read a novel or a short story, what the theme is. It's a central topic, a subject or message within the narrative. The character is a person in a narrative. It can be patients, patient relatives, friends, family members, all that. And the tone is writer's attitude towards or feeling about subject matter and audience, how a particular person, the author, feels about what he's going to discuss or the convey. So the premise of narrative medicine is that how a patient speaks about his or illness or complaint is analogous to how literature offers a plot with characters. And becoming conversant with the elements of literature facilitates understanding the stories that the patients bring. Every patient has a story that goes beyond the symptoms. Will tell us how a person became ill, the tipping point that compelled them to seek help, and the social challenges they face in getting better. And this promotes and nourishes empathy. So one will switch from asking how I can treat this patient disease to how I can help my patient. So narrative medicine in a nutshell, it draws on the study of art and literature to enhance one's listening and observation skills and to expand their views of patients to make them more than just medical stories. There are some examples of questions that can be asked, what you call exploratory questions and prompts useful in narrative medicine. Tell me about it. Tell me more. Is there something else? Or is there something that you are worried about? Or what is worrying you most? Has this ever happened before? What else was happening at that time? What do you think about it? What do others think about? And what does this mean to you? And what do you think might be causing this? How would you describe? And how do you explain? Then you must know how to stop or when to interfere and ask what you call prompts inviting change. If you think you are not going down the right lane, you change the line of questioning. What else might you explain? How else might you explain? Are there any other possibilities? What would happen if? What needs to happen for the situation to change? If the situation did change, what would happen then? Or what will happen if nothing changes? That's a line of questioning one can go through. And the teaching narrative medicine, we have not been taught. I think it's been introduced probably in Colombo faculty. Involves close reading of text, writing assignments of personal reflections about the text, and discussion of the personal reflections. With the development of narrative competence comes greater understanding and empathy that facilitate the patient and clinician working together. Examination, there's an art to examination. The age-old method of inspection, palpation, percussion, and auscultation. I still remember how late Professor Dharmadasa used to teach us how to evaluate the JVP, one of his very fond topics. Elicitation of tent and jerks. So much so, if you didn't have two rulers, one to keep vertically, other one to keep horizontally, the students were chased out of the clinical appointment, right? And elicitation of tent and jerks, examination of eye movements, how smoothly he used to do that, horizontal movements, vertical movements, right? So that art of doing all these things. And we know that most of the things are done nowadays in clinical labs, and a lot of people don't even see real patients, right? It has become a real problem in the States, and they have found that people coming from Asia have much more better clinical sense compared to their own trainees. And certain conditions, mind you, can be diagnosed only by examination. For example, Parkinson's disease, dystonias, and most of the dermatological conditions. Some other conditions where the examination is the most important. For example, heart failure. A lot of people think that heart failure is an echocardiographic diagnosis, and it is not, right? So it's from the history and examination, shortness of breath and pedal edema. Then you look at elevated JVP, lung vessel clefts, and the triple rhythm. And the echo will show you whether your ejection fraction is normal or not, or whether there's an underlying cardiac condition like valve disease or cardiomyopathy, or whatever, right? But the diagnosis is based on your history, examination, and of course things like chest X-ray and then biomarkers like BNP. So echocardiography is not the mainstay. Must remember that. And I will give you an example of how a diagnosis has been missed as a result of not paying attention to examination. I think I've shown this slide before. 65-year-old lady diagnosed as cryptogenic cirrhosis by a specialist gastroenterologist came because she was not getting better. And she was breathless, and the edema wouldn't go down. She had generalized edema, dyspnea, and she was severely anorectic. An examination showed generalized edema with elevated JVP, moderate ascites, right-sided pleural effusion, no peripheral stigmata of chronic liver cell disease. Albumin was serum albumin 3.5, ALT-AST marginally slightly elevated, and she had normochromic anemia with a hemoglobin of 10.5, normal WBC-DC and platelets, normal creatinine, right? And you know that platelet counts are generally on the low side in people with cirrhosis and portal hypertension, even in the absence of portal hypertension. An upper GI endoscopy showed mild portal gastropathy with early varices. And sorry to say that if you do 100 endoscopes, very rarely you get a normal endoscope, right? Every endoscope showed at least something, right? And so especially when it's done by an expert, you tend to accept it without questioning about the accuracy. So this patient, with all this, a diagnosis of cirrhosis was made. But there are obvious clues against a diagnosis of cirrhosis. Patient had generalized edema with an elevated JVP indicating a high right atrial pressure that is seen in right heart failure or CCF or volume overload as in end-stage renal disease. Intravascular volume is reduced in cirrhosis. Hence, JVP is not elevated unless there is stents ascites, pulmonary hypertension, or concomitant CKD. So this patient had none of that. So basically, in fact, I was suspecting heart failure and did this X-ray. I don't know whether you can see that. There's a very nice ring of calcification that's at the atrioventricular groove going right round. So this is an obvious case of constrictive pericarditis, and echo confirmed that. And we went on to do a CT, and this is a 3D reconstruction showing the nice ring of calcification. Unfortunately, this patient came quite late, and by that time he had decompensated and referred to the cardiothoracic surgeons. They did a pericardiectomy, but she succumbed to it, never recovered. Had the diagnosis been made early, the life could have been saved. That is because you didn't pay any attention to the JVP, right? Elevated JVP in a patient who is supposed to be having hypovolemia indicates that is something else. And as students, we always thought ascites out of proportion to leg edema, always think of cirrhosis, intraperitoneal malignancy, intraperitoneal TB, or constrictive pericarditis as third-year medical students. So these are just two examples of how the diagnosis was missed as a result of proper diagnostic sequence not being followed. That is leading to erosion of art of medicine. And wherever the art of medicine is loved, there is also love for humanity, said Hippocrates. Humanity is the quality of being humane, that's having empathy, kindness, compassion, sympathy, or consideration of fellow human beings. Humanities are academic disciplines that study aspects of human society and culture, such as history, philosophy, arts, language, performing and visual, etc. And medical humanities, one has to be humane to be a good doctor. Medical humanities are being introduced to medical curricula with the objective of producing humane doctors, having empathy, kindness, compassion, and sympathy and consideration for fellow human beings. Medical humanities include philosophy of medicine, medical ethics, bioethics, history of medicine, literacy, literary studies and religion, and social sciences and arts. I think it's being done in Colombo. The Colombo Medical Faculty was the first to introduce. Are there other faculties following it? Right. And there are different definitions given for medical humanities. There are given two definitions. First one, an integrated, interdisciplinary, philosophical approach to recording and interpreting human experience of illness, disability, and medical intervention. The second one, an interdisciplinary field concerned with understanding the human condition of health and illness in order to create knowledgeable and sensitive healthcare providers, patients, and family caregivers. Medical humanities will cultivate and preserve the necessary balance between rapid advancement of technology in science and medicine and humanistic care and caring. Evidence-based medicine tempts us to try to describe people in terms of data from biomedical science. These are not and will never be enough. Such evidence is essential, but always insufficient for the care of the patient. Conclusions: medicine without the element of art will produce medical robots without humane qualities, which differentiate human from artificial intelligence. Art of medicine is vital for providing holistic and patient-centered care. And doctors, while embracing the advances in science, should never forget the human element that defines practice of medicine. Every culture, every society has empowered physicians with respect and authority. We will be voluntarily giving up this if we lose the humane qualities. Ladies and gentlemen, so that is, we have to enrich clinical competence, but at the same time with compassionate care. Thank you.
On behalf of Sri Lanka College of Internal Medicine, let me thank my mentor, Dr. Bandula Wijesiriwardena, for that enlightening and thought-provoking lecture. Thank you very much, sir. Let me call upon Professor Piyusa Hathapath to hand over the certificate of appreciation to Dr. Bandula Wijesiriwardena.
Thank you very much, everyone. Moving on to the next session of today, that is a case-based discussion on interventional radiology. May I call upon Dr. Durga Manohari to conduct the session.
Good morning. Welcome to the case-based discussion in interventional radiology. I am Dr. Manohari Hettiarachi, specialist in internal medicine. Let me introduce our speakers today. Dr. Prasad De Silva, consultant interventional radiologist. He is from National Hospital, Colombo. And Dr. Pradeep De Silva, specialist in internal medicine from National Hospital, Colombo. So, interventional radiology is a rapidly evolving medical specialty which has dramatically changed the face of medicine over the last 2 decades. With evolving technical advances, most of the disease conditions which were used to be diagnosed or treated with traditional surgical procedures are now replaced with these minimally invasive image-guided procedures in interventional radiology. As internists, we need to have a sound knowledge about spectrum of interventional radiological procedures available either to diagnose or treat different diseases or their complications. So keeping this scenario in mind, let me invite Dr. Pradeep De Silva to open up this discussion. Over to you, Pradeep.
Thank you. Good morning, everyone. We will start with the case history and see what the interventional radiologist can give their input to this case. So the case history is, is a 58-year-old woman who presented with jaundice, bilateral ankle edema, and ascites. She had no history of alcohol intake or abuse or prolonged drug history. And next slide, please. So we investigated this patient, and her liver enzymes, SGOT and SGPT, are over thousands. Serum bilirubin is 5 milligrams. INR was 3, and platelet counts were 70,000. And screening for hepatitis A, B, and C were all negative, and ANA was done that was positive, 1 in 80. And anti-smooth muscle antibodies were also done. It was positive, more than 1 in 80. And now we are trying to confirm the diagnosis of autoimmune hepatitis. For that, the liver biopsy will play a very big role. So now our plan is to perform a liver biopsy on this patient with a INR of 3, a platelet count of 70,000, and a patient who has ascites. Under these circumstances, rather than going for the percutaneous liver biopsy, we thought it is important to go for a transjugular liver biopsy. So here, the interventional radiologist will help the clinicians.
Dr. Prasad.
Thank you. Good morning, ladies and gentlemen. It's going to be De Silva versus De Silva. That's me. Before going into the biopsy, I like to show some basic pictures of ultrasound and CTs. That's where you normally start, right? So basically, Pradeep must have done all these ultrasound and things. Management of cirrhosis is mostly nowadays done by the hepatologists and radiologists. I'm very proud to say that. Surgeons come into the picture only for transplant and, lobectomies and that sort of high-end stuff. But intermediate sort of things, the radiologists are managing. Right. Ultrasound is basic modality. I'm sure you are quite familiar with these pictures. This is the, I'm sure you can see the cursor. This is the ascites Dr. Pradeep was mentioning. And can you see this? Okay. Can you see this irregular margin? So with fluid, we can see this very well. So that's one of the salient features of ascites. Here, you can see a bit of a nodularity. You know all about micronodular, macronodular. This is macronodular. Micronodular you can't see, this is macronodular cirrhosis. When you open up, when the surgeries are done, these are felt as well as seen. I move. Then I like to talk few words about this new modality called elastography. It is available at NHSL and few of the leading private hospitals also. What does that do? That is the radiologist's way of palpating the liver. By saying that, I presume you understand what that means. You do all these palpations bedside. What you do, you just, apply some pressure into the liver and see its consistency, isn't it? The normal liver should have a reasonable amount of fleshy, soft cells in the fibrous, architecture. The abnormal liver will have more and more fibrous and less elastic tissues. I'm sure you remember this pathology stuff, right? So what will happen, we don't poke with our fingers, we poke with new modality called ultrasound wave. We send the ultrasound wave with the probe and see how the liver reacts. It is all done by the machine. All we have to do is keep a steady hand on the abdomen. But that will give us what we call an objective measurement. You remember all these pressure measurements in your A-level physics? Pascal, kilopascal? Yes. We give a measurement. Not we, the machine gives the measurement so that there is a range. The normal viewer will have a very small amount of pressure, whereas the abnormal, the other end of the spectrum is cirrhotic liver, will have a very high, which is very stiff. So that's a radiologist's way of palpating the liver, which is very good. Otherwise, what we do, we just eyeball the thing. My eyeballing with my, advanced age may not be, quite accurate. A younger radiologist may call it cirrhosis, whereas I may not call it cirrhosis because I think it's normal. But when it is elastography, it is objective. So it's not depend on the person who does it, right? Good. So it's available. You are most welcome to send to the NHSL. This is the picture of elastography. This is the picture showing all these colors. Radiologist's life is not black and white anymore. All the colors are coming up, right? I can still remember one of the leading physician, Dr. W.B. Wijesiriwardena, while I was the medical student. He used to call radiologists, Kalakanyas, Musalayas. You know why? We spend the time in the dark rooms, he said. Well, in a way, yes, but we are coming out of the dark. Our world is becoming more and more colorful now. This is a picture of CT scan showing the esophageal varices. All these things we can see. These are CT pictures showing again the same, showing again the irregular margins and all the ratios that we take, left lobe to right lobe ratio. All these things are there in the textbooks and, you can find enough internet stuff about this. All these pictures are from the internet. These are the measurements that we take to see the ratio from the caudate lobe to the right lobe, left lobe, etc. Okay. This is the biopsy gun. I just want to show you. Now I like to comment a little about Pradeep's request about the TJ, that is transjugular biopsy. I personally don't like it. Simply because it's expensive. You know how difficult to get these guns. Number two, it's more or less done under anesthesia, or rather at least deep sedation. And as Pradeep mentioned, ascites is a problem. INR, high INR is a problem. But now, with this coaxial gun, what we do, we put this needle first. Through that only, our biopsy gun goes in. So the track and everything is quite under control, as I call it. Quite under control. Unless you hit an artery or a vein, which I normally don't do, you are quite safe. You just put back that plunge inside once you have done the biopsy and wait. INR 3 means it's not going to clot in a hurry. Yes, I know. Take 10 minutes, take 15 minutes. But for our country, I think this is quite good rather than, it's like this, we can see, this is the liver. We can see the gun from the skin to the, needle from the skin to the place. Now for instance, here is a vessel. So I don't want to hit that vessel. This is quite real-time biopsies. We don't take the probe off. It's all the time. We have a look at the tip of the needle till we come out. Even when we come out also, the track is kept. Time to time, take the plunge out and see whether there is bleeding. So, controlling bleeding is not that bad. I presume I have answered the question. I'll go back to Pradeep.
So the liver biopsy was done and it confirmed autoimmune hepatitis, and the patient was started on prednisolone and azathioprine, and the patient was continued at the medical clinic. After about 6 months follow-up in the medical clinic, the patient's ascites got worse and she presented with hematemesis. Now again, with this thing, we thought of seeking help from our interventional radiologist. In which way he can help us.
Ascites, as we know, it's a collection of fluid in the peritoneal cavity. We can simply aspirate it. Some patients come maybe twice a week, depending on their how fast they accumulate fluid. If the ascites is not controllable like that, then you have this procedure called TIPS. TIPS means you are going to create a pathway from portal vein to the systemic vein. The systemic vein we normally choose is one of these hepatic veins. It is done within the liver, so that whatever mishap happens is cushioned by the liver. So what we do is like this, something like this. Now, here we come from the jugular puncture into the SVC, then into the IVC, and then we try to cannulate the portal vein like this. This is the most difficult part. I try to play this video. Sometimes, amazing, it's playing. See, it's coming. I don't have to tell anything. It's quite explanatory. So then what we do, we put a stent so that blood from the portal vein just goes into the systemic system. It's, now again, all these from internet, don't worry. Right, so I move forward. This is the stent. It's a metallic stent. There's a specific stent. Mind you, these are, amazingly expensive. It's about 2 million today, this stent. So, as somebody said, income from the alcohol is far more less than the expenses for the treatment. Right. This video is one of my patients. I wonder whether, okay, we can see it. Here, that's the most, crowning glory of this procedure, to see the contrast in the portal vein. Okay, here is another, there. So once you are in the portal vein, you put a guide wire, put a catheter, and then do all these balloon and plasties and put the stent, right. Then I move into the other complication, which is the HCC, hepatomas. Diagnosis again mainly radiological. People normally don't request biopsies for hepatomas. It's CT diagnosis is the one. It is well documented. There could be cases sort of in between, but about 70-80% of the hepatomas behave what the textbook says. And treatment also mostly radiological. I will go one by one. This is the type of enhancement you talk about. This large lesion. This is what we call the arterial phase. In the case of CT, we do different phases. One is non-contrast. Now, why I call it arterial? Can you see the aorta? I'm sure you are quite familiar with these pictures. The contrast is in the aorta, not, very difficult to get contrast only in the aorta. This is a fairly reasonable sort of, shall I say, NHSL quality CT. Nothing much in the IVC. Everything is in the aorta, and similar enhancement or similar whiteness in the tumor. That is the typical arterial type of enhancement that we talk about. Then there is another nice description regarding the venous washout. You all know our reports. If you care to go through them, we mention all these things. Early venous washout. So the tumor washes out earlier than the normal parenchyma. So we do 15 seconds, there's the arterial, and then do about 30 to 40 seconds another cut. That one will show that liver, the normal liver is still getting enhanced, whereas the tumor is becoming more and more darker, more and more blacker. So that's what we call early venous washout. Then there are, in between cases. They may not follow probably the tumor has not read the textbook, but we can see other things also. This is the type of hepatoma. Okay, I forgot to tell you. Why this tumor behaves like that? Because the normal liver will have about 75% of the blood supply from the portal system, whereas the tumor is from the systemic, from the hepatic artery rather than the portal vein. Therefore, the enhancement is more. That is where we come to do this little procedure called TACE. To do a decent TACE, we like to have good arterial type of enhancement, which means a hepatoma. So it tallies. Because you have a nice arterial supply, our life is easy. It will enhance when we are in the hepatic artery. The tumor will enhance and show us like this, nice ball. So all you have to do is just navigate your catheter here up to there and put all the chemo agents. I don't want to burden you all this onco stuff, but we can infuse only the tumor. That's the beauty of it. So, for instance, I keep on telling this thing to all my patients. Why not chemo? In other words, why not to Maharagama? Because it is given intravenous. Therefore, the tumor, actual place, will receive only about maybe 10%. I don't know what the percentage. It goes to the entire body and then goes to the liver, right? Whereas, when we do the TACE, at least 95% of the stuff, of the real stuff, goes into the tumor, which is very good. Somebody said, I'm sorry, that type of enhancement I could have shown, but this video did not behave the way I wanted. This is one of the TACE videos. Then we have all the other modern modalities. Microwave ablation, radiofrequency ablation. Now, I receive lot of requests saying TACE. I normally take it as the generic request. It's like, fever. We decide which way to go, whether to go for a TACE or microwave ablation. I just compare these two. TACE is good for tumors larger than 5 centimeter, right? Then TACE is palliative, whereas microwave or radio frequency, take it easy, both the modalities are same, both of them deliver heat. We put about 105 centigrade is the temperature that we acquire. Imagine at 100 water boils, no? So, body fish dancing inside. So, why this 5 centimeter division? Because the microwave needle or radio frequency needle will burn only up to 4.8 centimeters diameter nodule. So if it is, but it is curative. So about 4 centimeter nodule, microwave, radio frequency, which will cure. It cures. Take my word for that, it cures, right? We like to follow up with AFP, alpha-fetoprotein, but as you know, it's positive only in about 1/3, maybe 40% of the cases in Sri Lanka, I believe. Somebody has done a research on that. Therefore, if it is positive, that's good. Then we can see in about 3 months' time, AFP has gone to 0. Not 0, maybe less than 5. These are the type of needles we use, mere technicality. Actually, microwave is very much in prevalence in China. You know, they do from here. Okay, these one of the ultrasound pictures. Mind you, these things are done under local anesthesia. If somebody wants really have a bit of a pain and all, we can have deep sedation, but under local anesthesia, right? That's a very great advantage. This is how it burns. This is my needle. Here it comes. That's the culprit. We normally try to enter into the very center and go up to the, like that. And this this blackness will become white. This part will become white when you burn. Here it is. This moving structure here, probably you realize what it is. It's a heart. Don't worry, it's about few centimeters away. These are very safe, you know. Microwave has that ability of burning from. Okay, this is the radio frequency needle. I'm just running. Microwave can be done for the other lesions also, lung, kidney, prostate, thyroid. We do all these procedures at NHSL. Okay. Since I have about 1 minute, I like to advertise ourselves. I can see a lot of young guns. Future of Sri Lankan medicine is here. So we do mechanical clot retrieval of the brain for the acute stroke at NHSL 24/7. So please send us patients. Thank you very much.
Yeah. Now coming back to our patient, actually this TIPS was done, and as a complication of TIPS, the patient, there's one of the recognized complications of TIPS are he developed hepatic encephalopathy. That's the complication of TIPS, and we successfully managed that. And while following the patient, the ultrasound shows the liver lesion that Dr. Prasad has described, and the patient was, and the liver lesion was also treated as mentioned here. Okay.
This concludes our case discussion. We can entertain 1 or 2 questions from the audience, if there are any. Okay, let me ask one question regarding this hepatoma. Initially, we called triphasic CT to diagnose septoma. Now we are discussing about four-phasic CT. What's the difference between that?
It's interpreted in different manner. The three phases that you mentioned are arterial, portal venous, and delayed. That is the timing of the contrast. Some people do, anyway we do a non-contrast before all these things to make sure that there are no calcification, that sort of thing. Some call that a four-stage CT. Then there is a modern concept of doing temporal studies. That is, you find a lesion and then keep on cutting at the same place. The fourth dimension in a way. Now all these, these are time related also, how the blood supply goes and comes out and that sort of thing. Therefore, either way you can interpret. For me, personally, is the non-contrast is the fourth one.
Thank you, Dr. Prasad. Let me cordially invite our two speakers to accept the token of appreciation on behalf of the Sri Lankan College of Internal Medicine.
Thank you very much, everyone.